My name is Erum Hartung. I am a pediatric nephrologist at the Children's Hospital of Philadelphia. I appreciate the opportunity to speak with you today. I will be talking about ARPKD, clinical course, trial endpoints, and imaging. So my objectives today are to review the clinical features and progression of kidney and liver disease in ARPKD, discuss some of the barriers to clinical trials in ARPKD and some of the limitations of existing disease measurements, and review progress and future directions for new imaging biomarkers for ARPKD. So to start with reviewing clinical features and progression, as this audience well knows, the incidence of ARPKD is about 1 in 20,000 live births caused by mutations in PKD1 that encodes the protein fiber system polyductin. There's many different types of mutations, and the protein truncating or null mutations seem to produce the most severe phenotype, but there's many different types of mutations that can result in clinical disease. The key really for ARPKD presentation is that it is extremely variable. When many of us first learned about ARPKD, we were taught mainly about this classic newborn presentation, where these babies are often detected prenatally with having massively enlarged kidneys, with poor fetal urine output leading to low amniotic fluid or oligohydramnios, resulting in poor lung development or pulmonary hypoplasia, and death in about 30% of infants, and this is unfortunately true even with modern medical care. But even though that is taught as the classic presentation, that still comprises probably only about a third of patients. And overall, there's another 2/3 of patients that present either later in childhood or in adolescence. And these children generally have a milder disease progression, and some of them may have a liver predominant disease. In infancy, the main cause of morbidity and mortality is the pulmonary hypoplasia. And as I mentioned, this is due both to the low amniotic fluid, but then the other problem is that these babies often have very, very massively enlarged kidneys, and the simple mass effect of those kidneys pushing up and reducing lung volumes, as you can see in this X-ray here, can really cause a lot of difficulties. About 40% of babies will require a ventilator, and it's very common for these babies to develop a pneumothorax. The other major problem in the infant period is feeding difficulties. And again, it's those massively enlarged kidneys that can cause a lot of compression on the stomach and intestines and lead to feeding intolerance. And many of these babies will require NG or G-tube feeding. In the kidneys, what these babies have is very enlarged echogenic kidneys, as seen here by ultrasound. And the echogenicity comes from these millions of microcysts that arise from the dilated collecting ducts. So this is a figure of the appearance of a normal nephron on the left, ADPKD type cysts in the middle with these bubble-like outpouchings. And in contrast, the cysts in ARPKD are actually just the dilated portions of the distal collecting duct. And so histologically, this is what it would look like, where you have really the kidney parenchyma being taken over by millions of these small cysts that histologically are these dilated collecting ducts. And on ultrasound, you can't really see many actual cysts. You may see one or two, like these kind of dark black areas here, but essentially you're seeing just a distortion of the kidney architecture. And again, these kidneys are very large. This is from a 6-month-old baby who has kidneys that are larger than what you might expect to see in a grown adult. And most of these children will have some degree of progressive kidney disease, often leading to kidney failure. And I'll show you some of that data here. And so the disease, in terms of progression to kidney failure, the age at which that happens very much depends on the age at presentation. So this is some data from the NIH cohort study that was performed a number of years ago. And there's been similar findings in other studies as well. But what they saw was that when they examined people, divided people into whether they presented in the neonatal period, as shown in the blue line here, or if they presented later in life, as shown with the red line, the kidney survival was very different between those two groups. So as an illustration, if we look at when 25% of people developed kidney failure, that age for the neonatal presenters was around 11, whereas for the people who presented later outside of the neonatal period, the age at which 25% of people had kidney failure was closer to being in the 30s. So that really shows that there's very distinct groups of children who might benefit from ARPKD therapies. These very early and fast progressors, but then also a substantial number of people who may not develop end-stage kidney disease until later in life. So one challenge with ARPKD is that variability, and the variability in GFR decline even among people who are in that milder group. So this is data from a study that I collaborated on with Catherine Dell from Cleveland. And this shows data from a study called the CKID cohort study, which is a study of children with mild to moderate chronic kidney disease. And it's showing individual GFR trajectories over the follow-up. And so each of these colored lines represents a different child. And you can see that some children, like this one here, have quite a steep decline in kidney function over the follow-up period of a few years, whereas others might remain relatively stable and have some ups and downs. And so the same data is represented here with this plot, just showing that, again, some patients will have a very rapid decline and others will have relatively stable GFR over a follow-up period. So this poses challenges when it comes to following these patients and particularly in the context of clinical trials. Another key feature for ARPKD is hypertension, and this can often be out of proportion to the degree of chronic kidney disease. And often can be very difficult to control. So in that same CKID cohort study that I just told you about, and again, these are relatively mildly affected children with a median GFR of around 43, the vast majority of these patients were on antihypertensive medications, and about a third of them were on 3 or more medications. The mechanisms for hypertension are somewhat unclear. There's been animal studies that suggest increase in epithelial sodium channel expression, and intrarenal activation of the renin-angiotensin system. And so for that reason, ACE inhibitors or angiotensin receptor blockers are often preferred as antihypertensive therapy in these children. And then moving on to the liver, what these children have results from a developmental abnormality of the liver termed ductal plate malformation. And so just so you have a concept of what that means, I'll quickly walk through the normal pattern of liver development. So if you recall, in a mature liver, there are these structures called portal triads that consist of a portal vein branch, a bile duct branch, and a branch of the hepatic artery. Now, the way those portal triads develop is you have a portal vein branch within the liver that is surrounded by these ductal plate precursors that eventually undergo this series of remodeling events where parts of these ductal plate structures form the actual bile ducts, and then the areas in between are supposed to involute so that in the end you're left with one portal vein with one bile duct, as well as a hepatic artery branch that isn't shown in this picture. But what happens with ARPKD and some of the other ciliopathy diseases as well is that you have a failure of this ductal plate to involute and go through normal development. So you end up with these too many of these bile ducts, and then the bile ducts themselves can be dilated. So histologically, this is what it can look like. So on the left here, you see in the center is a portal vein. And then around it are these multiple bile ducts. So these, there's too many of them, and then the ones with the asterisk you can see are also quite dilated. And then what happens over time is that this leads to a fibrotic event. So this is another patient, and you can see the portal vein branch, and now this light colored area, this is all periportal fibrosis. And so you have this fibrosis occurring around the portal vein branches, and this is what leads to portal hypertension as well, because this impairs the intrahepatic portal venous flow. And so what that looks like in patients, and this diagram just illustrates the difference between what you might see in a healthy biliary tree shown on the right side of the diagram compared to a diseased biliary tree here, with features of either Caroli disease with these kind of dilated bile ducts in the slightly larger branches, or what's often more typical in ARPKD is some of these smaller branches having these dilated areas. That is one problem that can occur, and this is something that can lead to infections like ascending cholangitis. And then the fibrotic process that I mentioned with the periportal fibrosis leads to portal hypertension, where because of that fibrotic process, you have impaired blood flow returning from the spleen and from the intestines, leading to backup of blood into these esophageal or gastric varices, as well as the enlarged spleen and often dilated veins around the umbilicus. So clinically, as I mentioned, liver disease can be very variable. So there are children who will have no symptoms at all. If you were to do a liver biopsy on these children, you would see that ductal plate malformation, but for some reason, in some people, that does not progress to significant fibrosis or portal hypertension. Whereas in other patients, you can see the liver disease sometimes being the predominant problem or sometimes co-dominant with the kidney disease. So really that triad to remember for liver disease and ARPKD is the congenital hepatic fibrosis, that dilatation of the intrahepatic bile ducts that is associated with risk of ascending cholangitis, and the portal hypertension with the main manifestations being the enlargement of the spleen that then causes hypersplenism, meaning the spleen is eating up platelets, eating up white blood cells and causing those levels to be low, as well as the risk of esophageal or gastric varices that are associated with the risk for bleeding and sometimes need procedures like endoscopy to band the varices or inject them. And then in some patients where they're having recurrent bleeds, sometimes patients will require a procedure like a portosystemic shunt, such as a splenorenal shunt, to divert that portal blood flow. And this in the literature has been reported in anywhere from 10 to 40% of patients with ARPKD. And then about 7 to 13% of patients may require a liver transplant, either because they have severe portal hypertension or they have recurrent cholangitis that's not controllable by medical measures. And sometimes that ends up needing to be a combined kidney liver transplant, or sometimes one or the other organ will be transplanted first. So some other clinical features, one is growth impairment. So as I mentioned before, infants predominantly have growth issues really related to that mass effect of the kidneys, but then chronic kidney disease itself has an impact on growth. In Dr. Gay Woodford's cohort a number of years ago, they had observed growth impairment in about 30% of patients. And some early reports suggested or speculated whether this could be a specific effect of ARPKD, as it seemed to be maybe out of proportion to their degree of kidney dysfunction. But when we looked at this in the CKID cohort study, that same study of mild to moderately affected children, it seemed like children with ARPKD had similar levels of growth impairment compared to children with other causes of CKD. But regardless, growth impairment is an important clinical issue in all children with chronic kidney disease. And then another problem that we are starting to look at now and have a clinical study that will be starting soon, is the issue of vascular abnormalities. So there have been to date 7 cases of intracranial aneurysms reported in patients with ARPKD, some with severe consequences, including intracranial hemorrhage or death. And then another 2 patients that we reported that had extracranial aneurysms or other vascular malformations. And so this raises the question of whether fibrosystem polyductin, like the polycystins, whether it might have a role in vascular integrity. So, so I've told you about the general basics of the clinical presentation of ARPKD. And so right now, as in terms of taking care of these patients, we really have only supportive care to offer. And so I wanted to talk a little bit about some of the progress towards disease-specific therapies and some of the barriers for clinical trials. So as you know, there are currently no approved disease-modifying therapies currently. There's been several drugs that appear promising in preclinical studies, and I'll tell you briefly about a few of those. So one is tolvaptan, the vasopressin receptor antagonist, that, as you know, has been approved for treatment of autosomal dominant PKD. But in recessive PKD in the orthologous PCK rat, an orthologous model for ARPKD, tolvaptan did show some improvements in kidney cyst and overall kidney volume, as well as fibrosis. And these graphs kind of show that, where the white and gray bars are the treated animals compared to the black control animals, and they had lower kidney weight, lower cyst volume, and lower fibrosis volume. This is a drug that is now moving forward with clinical trials. There's anticipated pediatric trials coming up, one for infants and one for older children, and these are the numbers for clinicaltrials.gov. Another drug that has, another class of drugs that's appeared promising in animal studies are the somatostatin analogs. So octreotide or pasireotide, this is an example of one study where they showed benefit both for the kidney phenotype as well as for the liver phenotype. And so this is the kidney of an untreated PCK rat, and then a rat treated with octreotide, pasireotide, or a combination of both. And then in the liver, the untreated liver histology appeared significantly worse than animals that were treated with either drug. And these are an interesting class of drugs because these are already on the market for other indications, including pediatric indications. So perhaps a target for drug repurposing, but not something that has been looked at in kids with ARPKD yet. And then finally, tesavatinib is a multi-kinase inhibitor that, again, had some quite promising results in animal models, so both the BPK mouse and PCK rats. And this is just data as an example for the PCK rats, where both in the kidney and the liver, it appeared to significantly improve histology. So this is an untreated PCK rat kidney, and then this is the treated at low or high doses of tesavatinib. And then this is an untreated liver, and then the histology at 2 different doses. This drug did go through a phase 1 single dose clinical trial that focused mainly on pharmacokinetics and safety, but has not yet advanced to further phases. So clearly we have some really promising looking agents in preclinical studies, but nothing that has really moved forward meaningfully to efficacy trials yet. So what are the main barriers for that? So the area that I really focus is this here. So if we think about the conduct of a clinical trial, you have to have a number of patients with the disease that you would be able to randomize to the investigational drug versus placebo. And then you have to have this treatment phase where over some period of time that is feasible for the course of a clinical trial, so maybe 1 to 4 years, you have to be able to detect whether your drug is working or not, so that in the end you could make some conclusions. And so really one of the main problems that we try to address with our work is how can we find ways to really tackle this part where we find better ways to measure disease progression. So what is the problem with some of the existing disease measurements? So of course, we all know glomerular filtration rate is the best marker of kidney function. It's a very important marker. But at the same time, particularly in cystic kidney diseases, you can have a fair bit of underlying histologic or parenchymal damage without having that much of an effect on GFR, and that's because the nephrons that are relatively less affected can have compensatory hyperfiltration so that your overall GFR is still preserved despite having ongoing progression of cysts. The other problem also, as I showed before with some of the data in children who are with mild to moderate chronic kidney disease, the rate of GFR decline is relatively slow. And so you would need fairly large studies over a long period of time to really detect changes in GFR slope. The other measure that has been looked at in some previous studies is imaging. So that classic marker of that's used in autosomal dominant PKD, or total kidney volume, unfortunately does not work very well in ARPKD. So this is some data from studies where they've looked at the relationship between creatinine clearance and kidney volume. This is again from that NIH cohort study. And you can see that there seems to be somewhat of an inverse correlation between between creatinine clearance and kidney volume. But the problem is that there is a huge variability. So even, looking at children with this level of kidney volume with 300 ml per body surface area, there's a huge range of kidney function. And then that size relationship is much less strong in the older patients. And then the other problem is, unlike ADPKD, where you might be able to quantify cysts just based on standard imaging like MRI or ultrasound, that's not something that's really possible in ARPKD. And this is an example of an MRI in one of our patients who at the time was 16 years old. And here, the cysts appear bright white. So here you can see that he does have a couple of visible discrete cysts, but then the rest of his kidneys, there's just kind of diffuse areas that might look whiter, but this is not something that you could easily trace around and call it a cyst and measure it. And then in terms of the liver disease, we have similar issues with current disease markers. So thinking back again to those three components of the liver disease, so the first being that biliary duct dilatation, standard measures of looking at the liver can only really give you a qualitative assessment. So you might get a radiology reading where they say the bile ducts appear dilated, but there aren't really currently good ways of quantifying that. Liver fibrosis is tough with current measures because things like the liver function test that you might get on routine blood work, those tend to be normal or maybe only slightly abnormal. We do not tend to do liver biopsies in these patients because they're invasive and associated with risk to the patient as well as risk for sampling error. And then routine liver imaging protocols, again, just give you some qualitative descriptors such as heterogeneous echo texture or things like that, but nothing that's that useful as a quantitative measure. And then portal hypertension, as I mentioned, many of these patients will have an enlarged spleen, so that's something that's visible by ultrasound. They may get low platelet counts. But again, those can be things that develop later in the course of the disease. And in that NIH cohort study that I mentioned, 2 of 4 patients who did not have an enlarged spleen had varices on an endoscopy. So the clinical expression of the portal hypertension can vary from one person to another. So you could have a scenario where somebody has clinically significant portal hypertension with varices, yet have a normal size spleen or normal platelet count. It is possible to directly measure portal pressures, but that requires quite invasive procedures that are really uncommon in pediatrics, such as measuring the hepatic venous pressure gradient. And then endoscopies can be done to look for varices, but in children, those are not done routinely unless somebody has had a bleed. And again, it's because of the risks of sedation and procedures in children. So the bottom line is we need new biomarkers, and that's really going to be a key to advancing clinical trials of ARPKD therapies. And particularly since we're talking about children, the need for non-invasive biomarkers is huge. And then, as I mentioned, they really need to be quantitative so that they can be used in the context of serving as a surrogate endpoint. And then they need to be sensitive to differences in disease severity at earlier stages of disease so that you might be able to more appropriately select patients who could benefit from a clinical trial. And then they need to be sensitive to disease progression over a relatively short time frame, such as that 1 to 3 year time frame that might be there in a clinical trial. And so potentially as adjuncts to something like GFR. And so our work really has focused on imaging biomarkers. And really what we're trying to do is emulate what many of you have been involved with through the CRISP studies and try to come up with imaging biomarkers that may eventually be useful either for patient selection or as a surrogate endpoint. So in the kidneys, we've focused mainly on MRI methods. And so the concept here is that some of these newer MRI methods might be able to leverage some of those differences in cystic versus normal parenchyma to measure tissue differences that aren't visible by standard methods. And so some of the methods, and I don't have time to really get into the MRI physics here, but the bottom line is things like diffusion MRI, can look at the difference in the way that water diffuses based on the kidney, based on the tissue water content. And then this thing called diffusion tensor imaging can also quantify the directionality of water movement. And so that if you have a ordered tissue structure like you have in the kidneys, water will tend to diffuse in a certain way. And then if you disrupt that because you have cysts or other problems, then you can affect those parameters. And then there's things like quantitative T1 or T2 mapping, where it's possible to measure T1 or T2 relaxation times, and those would expect you would expect would be different between cystic and normal tissue. So I'll start by showing you work by Catherine Dell and Chris Flask in Cleveland. They really have been the pioneers in looking at kidney imaging biomarkers in ARPKD. So on the left here is work that they did in the PCK rat, which is as I mentioned, orthologous model for ARPKD. And here they quantified kidney cyst burden using T2 MRI. And you can see these are the MRI pictures over here, and this is the histologic comparison. And they were able to show that you can measure kidney cyst burden by MRI, and then when they sacrificed the rats and looked at and quantified cystic area histologically, this was very well correlated. And when they did kind of a little rat clinical trial with octreotide, they were also able to see differences in kidney cyst burden between the treated and untreated animals. And then more recently, they also looked at the BPK mouse, just because the PCK rat, even though it's an orthologous model, the appearance of the cysts is a little bit different than in human ARPKD, where the rat tends to have some of these larger cysts that tend not to be present in human ARPKD. Whereas the BPK mouse, even though it's not an orthologous model, does have these very tiny cysts that are maybe a little bit more similar to human ARPKD. And here they used mean T1 and T2 relaxation times, and they show that in these upper panels, these are affected mice at 2 different ages, and then the lower panel is a wild type mouse. And you can see that the shades of the lighter shades that are present in both the T1 and T2 maps correspond to longer T1 and T2 relaxation times. And they were able to show in these mice that these times do increase with age, so with increasing disease severity, and that they were consistently different than a wild type mouse. So this really laid the foundation for some of the human work. This is some work that we did at CHOP with diffusion tensor imaging. So this is again, a way of doing diffusion imaging where you can look at the directionality of water diffusion. And what we found was that, and this is just an example of the types of pretty pictures that you get. So this is a normal patient here with these multicolored lines showing the kind of tissue architecture and the fiber tracts that are naturally present in the kidney. And then this is a patient with ARPKD with a more significantly distorted tissue architecture. And this is something that you can quantify using this DTI, where you can measure something called fractional anisotropy, which gives you a measure of how disorganized the tissue is. And so the patients with ARPKD had lower FA values, indicating more disorganized tissue. And then it's also possible to measure these track lengths. And so the patients with ARPKD had shorter track lengths, showing that they had disruption of intact tubular structures. So these were our baseline results comparing healthy patients with ARPKD. And as and we're in the process of continuing to collect data longitudinally so that we'd be able to see how within an individual these parameters change over time. In Cleveland, Catherine Dell and Chris Flask have been working on a very exciting technology called MR fingerprinting. And this is a method of acquiring MRIs in a very short amount of time, about 15 seconds or so, that's resistant to motion, and especially exciting in the pediatric population just because it potentially eliminates the need for sedation and overcomes the motion issues that we frequently deal with in children. And so this is an example of just some proof of concept scans that they did in a healthy volunteer in these top panels and a patient with ARPKD in the bottom panels. And you can see for both the T1 and the T2 maps that the PKD patient had a much greater amount of bright areas compared to the healthy patient. And so this is something that can be quantified as mean T1 or mean T2. So this is a study that is continuing to enroll, and we're hoping to start to partner on this study as well in the future. And so in the liver, we have been looking at both ultrasound and MRI to quantify the liver disease. And the main focus of our work so far has been quantifying tissue stiffness as a way to get at that liver fibrosis piece. And so the first method that we used is something called ultrasound elastography, using acoustic radiation force impulse imaging. And so the concept here is that the ultrasound probe, which is the same type of probe that you would take ultrasound pictures with, it can send these high energy pulses through the liver and measure how fast that pulse travels through the liver. And that gives you an idea of how stiff the tissue is. And so we hypothesized that patients with ARPKD would have higher liver stiffness corresponding to liver fibrosis, and indeed that is what we found. So I know these box plots are a little busy, but I'll just quickly walk you through them. So on the left here, we have a comparison of the control patients, so these are healthy volunteers, compared to patients with ARPKD, and the three different colored boxes correspond to the left and right liver lobes and the spleen. So you can see, comparing each color to each other, that in the liver and the spleen, as a group, the patients with ARPKD had higher liver stiffness and spleen stiffness. And then when we broke that down into patients within the ARPKD group, separated out patients without any visible signs of portal hypertension based on whether they had low platelets or whether they had an enlarged spleen, and compared that to patients who clearly had clinical evidence of portal hypertension, we were still seeing differences in those more mildly affected ARPKD patients when comparing to healthy controls. So I think this actually is quite exciting in that it's a way that we could actually quantify an imaging difference in patients who don't otherwise have any clinical signs of ARPKD related portal hypertension, yet we were able to detect differences between those patients and healthy controls. This is just some additional data on those stiffness measures, showing that on the left here is correlations between liver and spleen stiffness and the size of the spleen, so meaning patients with worsening portal hypertension or higher degrees of portal hypertension and larger spleens had stiffer livers. And conversely, patients with lower platelet counts had higher liver stiffness measures. And then putting that together in terms of some ROC curves, well, this just shows that we had that the liver stiffness, particularly in the left lobe of the liver had quite high sensitivity and specificity for differentiating patients with ARPKD from healthy controls. And we found that this cutoff value really differentiated those two groups very well. And so currently we're continuing to follow the patients over time, and we're in the process now of analyzing how these measures change over time. And then lastly, the other way that we measured liver stiffness was MR elastography. So again, a similar concept of measuring liver stiffness. The physics is a little bit different in that this involves putting a vibrating mechanical driver on the outside of the body that then creates a wave within the liver that can then be measured by the MRI machine. But again, you end up with a number that corresponds to liver stiffness. And so similarly, we had fewer patients in this part of the study, since MRI, this particular MRI sequence does require the patient to lie still for a while. But again, we saw that patients with ARPKD, if you focus on the blue box here, had higher liver stiffness than control. The spleen, we did not find as much of a difference. And then again, these group sizes get quite small, but again, just showing some differences within the ARPKD group. The rightmost dots here correspond to patients with clinical evidence of portal hypertension compared to those who don't. And you're starting to see some indication that even within the ARPKD group, there's differences based on disease severity. And then this, again, is just showing that the liver stiffness does seem to somewhat correlate with spleen length and platelet count. We had fewer subjects here, so this didn't quite reach statistical significance. But then also that the MR elastography and ultrasound elastography measurements correlated quite closely. And this was actually good to see because in adult literature for other diseases, MR elastography is often considered the gold standard for liver stiffness measurement. But as you saw in terms of even our ability to do this in younger children, it's not feasible in younger children who can't tolerate MRI, whereas that ultrasound elastography can be done at any age. So this is really something that is exciting, in that it's a way to follow the liver fibrosis really in any age patient. So to summarize what our work so far, some of these novel MRI methods for kidney disease progression, like DTI and T1 mapping, appear to be, there's some early signs that they might be promising ways to measure kidney disease severity. And the new MR fingerprinting sequences might improve feasibility of MRI in young children. Ultrasound and MR elastography appear to be useful biomarkers of liver fibrosis and portal hypertension. One limitation is so far we haven't looked at biliary duct dilatation specifically, but I'll show you some of the work that we're planning to do to look at that. And then even though there were some correlations with portal hypertension, standard MR elastography measures are a little bit limited in really being able to quantify portal hypertension. So as I mentioned, we're continuing to follow these patients over time to look at how these measures change with disease progression. And then of course, once we have this data, we will need to also validate it in larger studies with more patients before we can really make definitive conclusions. So in terms of future directions, as I mentioned, we're going to be collaborating with Drs. Dell and Flask from Cleveland to explore additional MR sequences, including that MRI fingerprinting. And then one study that we're about to start at CHOP is methods to both quantify biliary duct dilatation and some newer sequences to get a better idea about portal hypertension. So I'll just show you some of the preliminary data we have with respect to that. So this is a technique called MRCP+, or quantitative magnetic resonance cholangiopancreatography. So this is a technique that is being done by a company called Perspectum out of the UK, where they have the ability to take MRCP sequences, and these are kind of standard MRCP sequences that might be done in a clinical setting, and they can quantify the bile duct architecture and put numbers to things like what is the total biliary tree volume, the number of dilatations, and a whole host of other parameters. And so this just shows what we might be able to see. So on the left here is an example of an otherwise healthy patient who had an MRCP done due to trauma, and you get a certain number for biliary tree volume, and this person did not have any dilatations. And then we happen to have had a couple of patients with ARPKD who had MRCPs done for clinical reasons. And the patient in the middle qualitatively just has mildly prominent bile ducts, but you can see her biliary tree volume does appear to be significantly larger than the other patient, the healthy patient. And then an 18-year-old patient who had much more grossly abnormal looking biliary tree just qualitatively had a higher biliary tree volume and number of dilatations. So we're going to be recruiting patients to kind of look at this more systematically and see if this could be a good marker for quantifying biliary changes. And then finally, the other part of that study will be looking at three-dimensional MR elastography. So this is a similar concept to what I showed you before with MR elastography, but this three-dimensional piece allows you to measure some additional tissue properties, which I won't really go into the MR physics because I don't completely understand it, but it's essentially different changes in liver texture based on different disease conditions. And so as you can imagine, in the general liver disease population, there might be different things going on, say inflammation, congestion, fibrosis, hypertension. Whereas in patients with ARPKD, really what we see is these last two columns. We see liver fibrosis and portal hypertension. And because this technique measures a greater number of parameters, we might be able to detect the difference between somebody who just has liver fibrosis as opposed to somebody who has liver fibrosis and portal hypertension, based on the difference in direction of how these different parameters move, and also tell them apart from other pathophysiologic processes like venous congestion. So in conclusion, I think it is an exciting time for ARPKD. There's a lot of basic science research that's showing us some very strong candidates for disease-modifying therapies. I think as we look towards advancing clinical trials, I think we'll continue to try to look for biomarkers of disease severity that could aid patient selection and serve as surrogate endpoints. And then as we're able to develop some of these candidate biomarkers, the next step will be to perform larger multi-center trials to validate these findings, working with the FDA towards getting some of these biomarkers qualified for use in clinical trials, and then of course partnering with patient groups and industry stakeholders to try to move these treatments forward to clinical trials. So I'd like to acknowledge my collaborators in the CHOP Department of Radiology, as well as my mentor in CHOP Nephrology, Sue Firth, and my study team, Mohini and Kate, collaborators in Cleveland, Drs. Dell and Flask, as well as my funding sources. And I thank you for your attention.